Hello, and thank you for the organisers for asking me to talk about radiotherapy for the treatment of Dupuytren's disease. In summary, I'm going to talk about radiotherapy for benign conditions. I'll touch briefly on the mechanism of action in Dupuytren's disease. We'll talk about previously reported data for primary radiotherapy for early Dupuytren's disease. And then I'll talk about some new things. First of all, a watch and wait strategy and results of a series of patients treated with post-operative radiotherapy. So most radiotherapy is used for treating cancer, and generally we use high doses of radiotherapy. For instance, roughly 60 gray might be a typical dose. But radiotherapy is also used for many non-cancer or benign conditions, and in Germany around 100,000 patients are treated each year. It has two basic actions. First of all, it reduces growth, so it works as an anti-proliferative, and it also reduces inflammation, so an anti-inflammatory. We tend to use low doses, so roughly 3 gray might be a typical dose for an anti-inflammatory indication, and 30 gray could be a typical dose for an anti-proliferative indication. And because we use low doses, side effects tend to be mild. So let's briefly look at the mechanism of radiotherapy in Dupuytren's disease. Really, radiotherapy mainly works in the early proliferative phase. And the more advanced you get, the less radiation sensitivity there is. It has multiple effects in a complex network of pathological processes. So it can affect the fibroblasts. It increases free radicals, causing macromolecule damage, including DNA damage. It modulates cytokines and disturbs signal transduction pathways. It has a direct effect on macrophages and also has an effect on endothelial cells. So let's start now looking at previous evidence, looking at radiotherapy in early Dupuytren's disease as a primary treatment. So if we look at the biggest retrospective study, or with the longest follow-up, this comes from Betts et al. From Erlangen. They looked at 135 patients, 208 hands, all of whom had progressive early stage disease, so disease that was worsening. 71% was stage N or N1 up to 5 degrees contracture, and 29% had stage 1 to 4. There was a median follow-up of 13 years. And overall, 69% didn't have any further progression. They also found that a shorter duration of disease led to a better response rate. So if we look at the results per stage, in stage N, there was only a 5% progression rate. Whereas in higher stages, there was a higher progression rate. And by the time we get to stage 2 to 4, really everyone progressed. So radiotherapy is not used in those stages. We then come on to the prospective study performed by Schmidt et al. This is treating patients with early Dupuytren's disease, so either stage N with no contracture or stage N1 with a contracture of less than 10 degrees. All patients had progressive disease. This was a randomized controlled trial comparing two different doses, 30 gray versus 21 gray. And they were either offered radiotherapy or some patients chose not to have radiotherapy, and they formed a non-randomized control group. There are 489 patients, so 718 hands were treated, and the follow-up was at least 5 years for all patients. And these are the very basic results. So this is comparing control, so those who did not have radiotherapy, with one of the groups, the 30 gray group, which was the better group out of the 30 gray and 21 gray group. And you can see that by 8.5 years median follow-up, 62% of the control group had progressed, whereas in the radiotherapy group, only 20% had progressed. And in the control group, 30% needed surgery for an advanced contracture, whereas in the radiotherapy group, only 8% of patients had surgery. So the conclusion of this is that radiotherapy reduces by 3 times the chance of progression or contraction needing surgery. In terms of side effects, acute side effects tend to be mild, so redness and dryness of the skin, grade 1, so not needing intervention in 25% of people, more severe redness or moist exclamation in 2% of people. There are chronic skin changes in 5% of patients at 12 months. Again, this tends to be fairly mild, and sometimes there is a bit of a change in heat or pain sensation. One worry is about radiation-induced carcinoma. The risk really is of the basal cell carcinoma mainly, in the skin in the treated area. And that risk is estimated at about 1 in 5,000 lifetime risk for a 50-year-old male. There is one case report in the literature of a child that got treated decades before with radiotherapy and did form a squamous cell carcinoma that spread. However, we do not treat children with Dupuytren's disease, and it's difficult to know whether this case is relevant. I'm now going to come on to a watch and wait strategy. I mean, you've seen already that radiotherapy can be used effectively in early progressive disease, but actually many patients do not actually progress, so that often patients don't need radiotherapy. So if there's no progression and no loss of function, then really watching and waiting will be the right thing to do. And progression is defined in this context as an increase in palmar or digital disease, so new nodules, cords, skin retraction, or growing nodules and cords, or loss of function, so loss of hyperextension, loss of finger span, or contracture formation. So a watch and wait strategy would be composed of serial assessments over time in order to prevent overtreatment with radiotherapy if the disease stays stable, or in order to time the initiation of radiotherapy if there's progression. So the first thing I tell patients to do is to draw around the nodules and cords with a felt tip pen and take a photo with a ruler by it. So you can see in the central one there was a very small amount of disease and I've put a ruler by it. Clearly if there's significant disease that's affecting function, then that will be an indication if it's progressing or affecting function for radiotherapy, and you can see that there are serial assessments taken here. The second thing to measure is loss of hyperextension, so I tell patients put your hand on a tabletop, press down on the MCP joint, raise the finger as far as possible from the surface, and then measure the distance between the fingertip and the table, and then do this for all 10 fingers. And this gives patients an objective measure of whether there's a reduction in hyperextension over time. The third thing I tell patients to do is to measure finger span. So I say put your hand on a piece of paper, spread your fingers and thumbs as much as you can, and draw around the fingers on a piece of paper. They can then take measurements between various fingertips, again as an objective measurement serially over time. And this figure is courtesy of Professor Siegenschmidt, who's been using this technique since 2011. So I tell patients to do these obviously at baseline and then every month or two. If there's stable disease, then they simply continue to watch and wait. If there's a significant serial deterioration, then I ask them to come back to me and then we can consider whether radiotherapy will be an appropriate treatment to reduce progression and reduce the risk of contracture needing surgery. We now come on to the other end of the spectrum, post-interventional radiotherapy. So there are two main questions here. Firstly, does adding radiotherapy early after intervention reduce the recurrence of the contracture? And second of all, if the Dupuytren's disease recurs long after the intervention, what are the outcomes and safety profile of radiotherapy? So in order to look at these two questions, there was a retrospective study done on patients treated by Professor Siegenschmidt at 4 locations between 2005 and 2020. Intervention was defined as contracture release for functional improvement by either needle fasciotomy, collagenase injection, or limited fasciectomy. And the follow-up was a mean of 5.5 years, and all follow-ups were more than a year. It should be noted that this data has been submitted as an abstract for ESTRO conference next year. So looking at the patient groups, I divided them into early radiotherapy, so less than 3 months after the intervention, or delayed radiotherapy, which was more than 3 months after the intervention and up to 40 months. In terms of the early patients, again, they've been divided into post-needle fasciotomy, post-collagenase injections, of which there are only a few because collagenase became unavailable, and post-limited fasciectomy. In terms of the delayed patients, this was after any of these interventions. You can see the numbers here. And the other thing that I would note strongly is that these patients, 75% of them had had at least 2 previous interventions. So these are mainly not primary intervention treatments. So let's look at the radiotherapy treatment. So in terms of timing, after either needle fasciotomy or collagenase injection, radiotherapy was started at around 2 to 4 weeks after those interventions. After limited fasciectomy, the local healing was waited for, and therefore it was more like 6 to 12 weeks. The radiotherapy was given in 2 phases, exactly the same as for primary radiotherapy. So that would be phase 1, 15 gray and 5 fractions, that's 5 treatments over 1 week, a gap of at least 12 weeks, and then the second phase of 15 gray and 5 fractions over 1 week. The first phase for all patients was a wide field to encompass all previous intervention sites and all palpable disease. In terms of the second phase, most patients again were treated with a wide field, but for the limited fasciectomy patients where there was a desire to not give too much dose to the surgical site, that surgical site was missed out on the second phase. So in other words, those patients, the surgical site would get only the phase 1, the rest of the hand would get the full 30 gray. And this is an illustration of that. On the left, you can see that phase 1, the surgical site was included. Phase 2, some of the surgical site was not included there. Whereas post-needle fasciotomy, the whole wide field was given the 2 phases of 15 gray and 5 fractions with no contraction of the second phase. So the general outcomes, patient assessed in terms of cosmetic and functional assessment, you can see that 59% of them felt it was either excellent or good, 16% satisfactory, 25% felt it was poor, although of course that may well be related to failure of radiotherapy, in other words, progressive disease. In 40% of patients there was chronic dryness, which is in line with the data from primary radiotherapy. And importantly, there was no ulceration, no deep wounds, and no infections. So let's look at progression. So in other words, contracture progression in a bit of detail. Now, the primary outcome for this study was a progression of more than 10 degrees. And you can see that the figures here range between 28 and 43% in terms of progression given that definition. In fact, the 43% was based on very, very low numbers after collagenase injection, but still, those were the, using that definition, those were the outcomes. However, most people do take more than a 20-degree increase in contracture as a hard endpoint after surgical studies. And if we look at that, then really it's between 10 and 17% if you discount the 43% from the collagenase. And that really is starting to look quite impressive. If we look at that compared to typical figures from the literature post-intervention, of course you are looking at slightly different groups. So after intervention alone, this is primary data. Follow-up tends to be about 3 to 5 years. And for needle fasciotomy, after intervention alone, roughly recurrence rate of 50 to 60%. Same with collagenase, but after limited fasciectomy, probably around a 20% recurrence rate. And you can see that the group's slightly different in the surgery plus radiotherapy group. So as I said to you before, 75% of these patients had at least 2 interventions. The follow-up was a little bit longer than the literature, and you can see that actually the figures are very favourable, particularly, of course, if you discount the collagenase group, which was very small, then 10 to 17%, I would say is pretty impressive, albeit obviously on a selected group of patients in a retrospective study. So in conclusion, this is the first series presented about post-interventional radiotherapy in Dupuytren's disease. There were favourable outcomes compared with the typical published results of intervention alone. This was safe and really a similar profile to primary radiotherapy. There were good patient-assessed outcomes, but of course we await the definitive results from the adjuvant arm of the DEPART trial, that's an Australian trial, which is a randomised controlled trial of radiotherapy versus no radiotherapy, both in the primary setting but also in the adjuvant setting. So my overall conclusions. Radiotherapy is effective in early progressive Dupuytren's disease. A watch and wait strategy should be used for patients who have early disease without proven progression. And post-interventional radiotherapy is safe and shows promising results, although definitive data are awaited. Thank you.